Today we are going to speak about diabetes mellitus clinical pharmacology. I am Dr. Hassan, Associate Professor of Clinical Pharmacology, Drug Therapy and Clinical Research. In this series we are going to maybe cover the several aspects of clinical the pharmacology of diabetes mellitus, start from a brief review of physiology and pathophysiology, moving to the clinical signs and symptoms of diabetes, classification of diabetes. Then we go to the pharmacological approach and pharmacological or like management of diabetes that include non-pharmacological approach and pharmacological approach. In the pharmacological approach, we are going to cover the medication given like injectable medication and non-injectable medication. So for the injectable medication, we are going to speak about the insulin and other group of medications such as Ozempic, belong to the GLP-1 and the GIP medication. We have Pramlintide, for example. For the oral hypoglycemic agent, we are going to speak about Sulfonylureas, Metformin, Glitazone, and other group of medication. And we have another maybe new introduced to the market like medication affect the SGLT transport in the kidney, such as empagliflozin and canagliflozin. So we are going to cover all these agents and drugs in this lecture. I hope you will find this lecture interesting and beneficial for everyone who is listening to this lecture. Okay, as an introduction for the diabetes mellitus, the definition of diabetes mellitus is a metabolic disorder or metabolic dysfunction characterized by persistent elevation of blood glucose level and irregularity in carbohydrate, fat, and protein metabolism. So we have blood sugar high in this case. The blood sugar, the glucose, if you measure the glucose in blood, you find that glucose is high. In the absence of successful interventions, that what we have here, if you don't have an appropriate treatment to your patients, the result will be immediate complications. So in this case, we talk about like early symptoms of hyperglycemia. So if the patient left untreated and the patient suffer from severe hyperglycemia, the patient may come to the emergency room, suffer from diabetic ketoacidosis, or hyperosmolar hyperglycemia syndrome. So we have two cases, diabetic ketoacidosis or hyperosmolar hyperglycemia syndrome. This is require immediate treatment in emergency department or emergency room in AR. Now this is talk about the acute complication of diabetes. What about the chronic complication of diabetes mellitus? Any chronic complication, they said if we left the diabetes mellitus without treatment, and that is associated with a high level of blood glucose for long-term high level of blood glucose, this will lead to the complication that affect the microvascular, small blood vessel, macrovascular, and associated with the neuropathy. So we have, you can see here, affect two type of blood vessels in addition to the neurons. If we left the blood sugar without treatment or control. Okay, before we go in depth in the, regarding the clinical pharmacology of diabetes mellitus, this slide here reminds us with the major hormones. We have another hormone, but this is a major hormone produced from the pancreas, considered like peptide hormones. We have glucagon produced from alpha cells. We have insulin produced from beta cells. Then we have somatostatin produced from delta cell. So we have three major types. We have alpha, beta, delta. Alpha responsible for secretion of glucagon, beta responsible for secretion of insulin, and the delta responsible for secretion of somatostatin. Okay, these hormones play important role in regulating blood glucose. So you can imagine here glucagon, increased glucose, blood glucose, insulin, decreased blood glucose. Somatostatin could be maybe has inhibitory effect on the secretion in general. What we have here, patient may come to the clinic or to the healthcare centers, suffer from relative lack or absolute lack of insulin, uh, which lead to the diabetes mellitus, and this associated with hyperglycemia. So when you have deficiency of insulin, this deficiency could be relative or could be absolute lack of insulin. We don't have any insulin in our body. The result, the patient will suffer from hyperglycemia. If the patient left the case without treatment here, if the situation left without treatment, the patient may suffer from complication of hyperglycemia, which include retinopathy, nephropathy, neuropathy, and cardiovascular complication. Therefore, it's important to treat patients suffer from diabetes mellitus to avoid complications, especially you can see here the eye, the kidney, the nerves or neurons or central nervous system. Then we have cardiovascular system. So it's very important to treat patient who is suffering from the diabetes mellitus, even type 1 or type 2. Okay. Diabetes classifications, here we have two major types. We have type 1, type 2. We have diabetes could happen during pregnancy. We call this type like gestational diabetes, and we have another type of very rare type of diabetes, genetic diabetes, 1 to 2%. So you can see type 1 diabetes maybe occur by 5 to 10% of population, but 95% happened according to the type 2 diabetes. Type 1, 5 to 10%, type 2, 95%. Gestational diabetes occur during pregnancy. Gestational diabetes, then we have genetic diabetes, belong to the 1 to 2%. It's like one of the most maybe known genetic disorder, maturity onset diabetes of the young. So here we have MODY type of diabetes. So 4 type, but this is a major 2 type of diabetes mellitus. Okay, management. Here we talk about the primary goal. What is or are the primary goal of treatment of diabetes, the management of type 2 type 1 or type 2 diabetes, to addressing multiple goals. You can see here primary goals to control and prevent complications. So this is the main goal of maybe treatment of diabetes. Number 1, to control the glycemic. So glycemic control in order to prevent complications. So what is the aim or purpose of treatment diabetes? To control glycemic and prevent complications, especially talk about micro and macro vascular complication. When we talk about micro vascular complication, here we talk about small blood vessels. We are talking about retinopathy, nephropathy, neuropathy. When you speak about macro vascular complication, large blood vessels, coronary artery, peripheral arteries, and cerebrovasculature. So you can see here, if the patient left without treatment, the patient may suffer from complication. This is a chronic complication, not acute. Acute, we have 2 cases there. Okay, moving to the type 1 diabetes. Type 1 diabetes maybe consider 5 to 10% of the prevalence of diabetes. Characteristic of type 1 diabetes. This type of diabetes belong to the autoimmune disease. This autoimmune disease lead to the destruction of pancreatic beta cells, and we are going to have no function. We have absolute deficiency of insulin. We have 0 insulin in this patient. We don't have insulin. Okay, usually we see this one in children and adolescents. We have some cases in maybe in adults, but it's very rare and most common in children and adolescents. If you look on the patient, patient often thin or normal weight, without functioning of beta cells. The pancreas fail to respond to the glucose. When the blood glucose high, okay, we don't have enough insulin to bring the glucose to the normal level. The patient may suffer from the polydipsia, polyphagia, polyuria, weight loss. How to treat the patient here? The treatment will include insulin. So the best way to treat this patient, we need to prescribe insulin, and most commonly subcutaneous. And we have several types of insulin need to be prescribed to the patient. Could be short acting, rapid acting, intermediate, or long acting. We are going to discuss that in the next slide. So type 1 diabetes, we have autoimmune disease, lead to destruction of pancreatic cells. We have no insulin. The patient often thin and happen with the children and adolescents. The patient may suffer from polydipsia, polyphagia, polyuria, and weight loss. Here we need to put two lines under weight loss because comparing with the type 2, the patient suffer from weight gain. If you need more definition, for example, here. Okay, polyphagia mean excessive appetite or eating. Polyphagia, excessive appetite or eating. Polydipsia is like excessive or abnormal thirst. Polydipsia, and polyuria, excessive secretion of urine. So we have excessive appetite, polyphagia, polydipsia, excessive or abnormal thirst, and polyuria, excessive secretion of urine. Okay, type 1 diabetes. What about type 2 diabetes? Type 2 diabetes may be considered like 90 to 90% of cases of diabetes. Is the most popular case of diabetes. Normally happen or occur between after 40 years of age. This is for the adult, during the adult life. Often happen in obese person. Here we have maybe two main cases associated with the type 2 diabetes. Number one, we can see the increased insulin resistance, increased tissue insulin resistance. The tissue and organ resist the insulin action. So we call this one increased insulin resistance or decreased sensitivity towards insulin. So we have increased resistance or decreased sensitivity, impaired insulin secretion. So we have two main things. Number one, resistance. Number two, secretion. We have increased resistance and decreased secretion of insulin. Some study found we have reduced incretin effect. We are going to speak about this type of hormones later on, and we have considered like target for some medications. Other maybe research or literature review discuss the role of transporter or cotransporter called the sodium glucose cotransporter 2 SGLT2 in the kidneys. What they found there from the name sodium glucose cotransporter, if you have the kidney here, and this is the proximal tubules, we have cotransporter. This cotransporter responsible for reabsorption of sodium and the glucose. Okay, sodium and the glucose. This is a urine here. This is the cells, and we have here blood. So this is a cotransporter responsible for transport sodium and glucose from the urine back to the blood. So what happened here? They found we have upregulation. Upregulation here mean increased number of transporter. So we have more transporters in the, so you can see here we have more transporter that bring the glucose back from the urine to the blood. Therefore, the patient suffer from hyperglycemia. So all these like theories or possible maybe explanation what happened in type 2 diabetes, increased resistance towards insulin or impaired insulin secretion, reduced action of incretin, and upregulation of sodium glucose transporter. How to treat patients with type 2 diabetes? What is the option available for the patient? Okay, to start with the lifestyle modification, increase exercise. This is number one. Then the second step, we go with the hypoglycemic agent. Normally, you go with oral or injectable, depends on the case. Then we have the last step. If the patient does not maybe response, we go with the insulin injection. So start first, healthy lifestyle, exercise. Second, hypoglycemic agent, and the last step will be insulin if needed. Okay, so what we can see here, this slide here demonstrates the pathophysiology of type 2 diabetes. We have two main mechanisms that explain the type 2 diabetes. Number one, we have insulin resistance, increased peripheral insulin resistance, such as we have muscles, we have deposit tissue that resist the effect of insulin. So in this case, we don't have the ability to decrease uptake of glucose from the blood. So unable to uptake the glucose from the blood. So the glucose level in the blood will be high. So unable to uptake glucose from the blood because we don't have insulin. This is number one. So the first mechanism, increase insulin resistance. The second mechanism, we know that the beta Langerhans and the pancreas responsible for the secretion of insulin. So the second mechanism, they found the pancreas produce less insulin. So we call this one decrease insulin resistance. Okay, how to treat patients with type 2 diabetes? Number one, we try to maintain blood glucose within normal limits. We are going to discuss what is the normal limit of a glucose, what is the normal value. This is number one. So we need to control blood glucose. And number two, prevent complications. We discuss the microvascular and macrovascular complication. Okay, so we start with the patient with type 2 diabetes, start with recommendation of weight reduction if the patient obese, exercise, dietary modification. All these maybe process will decrease insulin resistance and correct hypoglycemia in some patients with type 2 diabetes. However, they found that most patients require pharmacological intervention. So most patients need to go with the treatment, even when the weight reduction, exercise, when the lifestyle modification does not offer enough control of blood glucose. We have to go to the next step. So first step, lifestyle modification. The second step will go to the pharmacological intervention. The third step, with the chronic development of the disease, when the disease progress, beta cell function decreases. So for example, after 10 to 15 years of the diabetes type 10 to 15 years of type 2 diabetes, the patient will need to go to the insulin therapy. Okay, this slide here represent the glycemic target recommendation for most adult patients with diabetes. This is a recommendation for the lab test, blood test value, and this one should be for 12-hour fasting, for example, especially for the second one. Fasting blood glucose should be 80 to 130 or less than 110. According to we have two association, as you can see here, American Diabetes Association or the according to the American Association of Clinical Endocrinologists. So what we have here, the first association recommend the range between 80 to 130. The other association, they said less than 110. So depends on the range. This number one. A1C, for according to the ADA, they said less than 7%. According to the endocrinologist, less than or equal 6.5. Peak postprandial glucose less than 180 and less than 140. So we have two criteria, and in general summarized in this table here. Random, this one A1C, hemoglobin, glucosated hemoglobin. This graph here, or this table, maybe to diagnose the patient with diabetes, to say this patient suffer from diabetes mellitus. If you go to previous table here, this is the normal blood value for the healthy subject, or for the subject treated with a medication to control diabetes. So if you have patient suffer from diabetes and you treat this patient, your blood test result will be looking for the ideal result will be A1C less than 7%, fasting glucose 80 to 110 or 130 or less 110, and postprandial 180 or 140. Depends on the association. But how we can diagnose your patient? We diagnose patient with diabetes. The criteria for diagnosis diabetes: A1C more than 6.5% or equal, fasting glucose more or equal 126 milligram per deci, 2-hour plasma glucose more than or equal 200 milligram per deci, random blood glucose more than 200 milligram per deciliter. So this diagnose number one, A1C. A1C hemoglobin, glycosated hemoglobin, that measure the glucose in the red blood cells, which last for the previous 3 months, and this gives us the history of blood level during this 3 months, to know if the patient control with the anti-diabetic medication or hypoglycemic agents. Okay, so now we have a pharmacological approach to glycemic management, standard of care 2023, according to the Diabetic Care Journal, published in the on their website. I tried to share the screen with you. So what we have here, so this one according to 2023, as you can see, a pharmacological approach to glycemic treatment standard 2023. Okay, this table here is the most important table, few large, we can see it together. Here we have the maybe the best way to approach patients suffer from diabetes mellitus. So in this table provide a lot of information. Use of glucose lowering medication and the management of type 2 diabetes. Okay, number one, if you look what we have here, the first line, healthy lifestyle behavior. Okay, self-management, education and support. Okay, goal of therapy, we have two main goals. Number one, and if you look on the what we have here on the left side, okay, we have cardiovascular risk reduction in high risk patient with type 2 diabetes. Cardiovascular risk reduction, here we have cardiovascular risk. Okay, and the second column, our maybe goal to achieve plasma control plus weight management. So we have two cases here. Number one, patient with the diabetes and high risk of cardiovascular disease. The other maybe group of patients suffer from diabetes and overweight or obesity. So what happened there? They said we have also several criteria here. If the patients suffer from atherosclerosis, cardiovascular disease, how we are going to approach the patient? They said go with the GLP-1, or go with the sodium glucose transporter 2 inhibitor such as empagliflozin, or GLP-1 such as Ozempic. So if the patient suffers from cardiovascular disease plus diabetes, we go the empagliflozin as a maybe example for SGLT2 or GLP-1 such as Ozempic. If the A1C above target remain above target for the patient, maybe we can do the combination treatment. We have to assess the cardiovascular risk factor. What about the second step here? The patient here suffer maybe indicate high risk of cardiovascular disease. The patient maybe more than 55 years old, and more additional risk factors such as obesity, hypertension, smoking. We need to look on the atherosclerosis cardiovascular risk and assess. Again, this is number one, atherosclerosis cardiovascular risk factors. What happened with heart failure? What is the major medication for heart failure? So heart failure here with the diabetes, type 2 diabetes, the main medication, the ideal medication for heart failure, I will go with the empagliflozin, canagliflozin. So heart failure, SGLT2 with the brufen of benefit in heart failure in this population. Okay, last one here, CKD. Patients suffer from chronic kidney disease. The GFR less than 60 per 1.73 square meter, or albuminuria more than 3. What we have here, what is the ideal medication for this patient? The ideal medication, we can look what we have. Okay, we're still going with the SGLT inhibitor, such as empagliflozin, canagliflozin. Okay, now that's next. We have another option. We go with the sodium glucose transporter inhibitor, or with the GLP-1 agonist. So we have two options there. Okay, move to so what we have here, as you can see, we discussed three cases: atherosclerosis, cardiovascular disease, heart failure, CKD. Looking on the other maybe side here, you can see the patients are from hyperglycemia and weight or obesity. What we can maybe prescribe to your patient here depends on the efficacy of medication. In general, high efficacy approach have a greater likelihood of achieving glycemic control. Very high achieving control, you can see it here, semaglutide. Okay, for the overweight. Okay, we have semaglutide. Then we have dulaglutide or insulin, combination of these medication. Okay, here we have the management. So what we have here only to control glycemia or control glucose only. Here, if the patients are from obesity and diabetes, the drug of choice, very high effective drug of choice will be semaglutide or tirzepatide. This belongs to the GLP agonist. High will be liraglutide, dulaglutide. Intermediate will be GLP agonist, and neutral will be DPP4 inhibitor and metformin. So this maybe the guidelines according to the new guidelines. According to maybe the Diabetic Care Journal of American Diabetes Association. Okay, so we're done with the maybe guidelines how to approach the patient with the GLP-1 or with the SGLT or with the insulin, with metformin. I would like to go back again to this slide only to show you something, because we maybe missed that. It's very important, maybe steps to look. Okay, so you can see here in this slide and this one here, glycemic management choose approaches that provide the efficacy to achieve goal. You can see here metformin or agent include combination therapy that provide adequate efficacy to achieve and maintain treatment goals. So if the patient come only suffer from diabetes, metformin remain the first group of medication, the first medication for newly diagnosed patient. So metformin remain the best medication. But if the patient suffer from heart failure, we go with the HGL2. So we have empagliflozin and empagliflozin. CKD, empagliflozin, empagliflozin. Atherosclerosis, empagliflozin, empagliflozin, or Ozempic. So you can see metformin here. We still have metformin in the location for the treatment. Okay. Moving to the first agent used to treat diabetes, we have insulin. And the question, insulin can be used for type 1 diabetes mellitus and for type 2 diabetes mellitus. This is a clinical use for the type 1 and type 2, but for type 2 it's not the first drug of choice. We have other medications start with oral, ending up with the insulin after 10 to 15 years. So what we have here, we need to understand the mechanism. Insulin secretion is stimulated by increased blood glucose. When you eat food, when you eat glucose, when you eat take sugar, for example, the blood glucose will be increased, and the result will be increased secretion of insulin. When the glucose taken up by the glucose transporter, the glucose enter the cell, okay, into the beta cell of the pancreas. Okay, so when the glucose enters the cell through the glucose transporter, what happened here? We have a glucose metabolism. We have system to metabolize glucose. When you metabolize the glucose, the result will be generate energy, generate adenosine triphosphate. This one produce energy. This is ATP will cause a blockade of potassium channels. Closing potassium channel will lead to the depolarization. Depolarization will lead to the influx of calcium through the calcium channel. Okay, this will lead to the increased level of calcium inside the cell, intracellular calcium, and ended up with the insulin exocytosis. And we are familiar with this terminology here. When you say exocytosis, mean release of content of the beta cells to the circulation, release of insulin to the circulation. Okay, you can see here from the slide okay, let me explain the slide for ourselves here. What happened here when you take a glucose? So the glucose will be in the blood. Okay, when you take glucose, the glucose from the blood, okay, arrive to the cells and tissues. It's not easy to write on the screen. Okay, when the insulin coming from the food, for example, arrive to the blood, and the glucose enters the cells through transporter called glucose transporter. We have GLUT2, glucose transporter 2, and when the glucose enters the cell, the glucose will be metabolized and produce ATP, produce energy. This energy lead to the closed potassium channels. Closing potassium channel cause depolarization. Depolarization of the potassium channel or the cells. Depolarization of the cells lead to the opening calcium channels. Opening calcium channels, you can see it here, lead to the increased influx of calcium inside the cells. Influx calcium inside the cells will lead to the engulfing of vesicles that contain insulin. This is the insulin here, and the vesicles will engulf with the cell wall here and release the content through mechanism called exocytosis. Now we understand the mechanism, how this mechanism works. Number one, glucose enter the cell, metabolized, produce ATP, ATP close potassium, potassium cause depolarization, which activate calcium channel, open calcium, allow calcium to enter the cell. Then the calcium will start digging on the vesicles of insulin vesicles and release the content to the circulation. We now understand the situation. Okay, moving to the next slide to understand what happened there. What is the action after the insulin arrive again to the blood? Now we have insulin in the blood. What happened? What we speak about? What about insulin action on the human body? Okay, now this slide to summarize or maybe present a list of action for the insulin. Number one, they said insulin stimulates glucose uptake into the muscles and in the bone tissue. So we need the insulin will allow glucose to transport from blood to the muscles. We need the glucose for our muscles to start to give some energy and power to our muscles. The bone tissue here, the bone tissue for storage. So normally when the glucose arrives to the adipose tissue, will store in the adipose tissue. But when you talk about the muscles, we need glucose for to use it for the energy. Okay, number two, stimulate hepatic glucose uptake. So allow glucose will uptake glucose by the liver. The liver will bring glucose to the cells and tissue. Bring them from blood to the liver. Okay, stimulate amino acid uptake and protein synthesis. Okay, and sometimes we consider insulin like anabolic agent or anabolic hormones. Okay, so stimulate amino acid uptake and stimulate protein synthesis. So for this reason, we consider insulin like anabolic agent. Insulin inhibit hepatic glucose production, will lead to the decreased glucose in the blood. Inhibit breakdown of triglyceride in the adipose tissue. Inhibit protein degradation. This one is similar to the first one there. Enhance synthesis and inhibit degradation. So all these bring that topic to the light by saying that insulin move glucose from blood to the tissues or to the cells inside the cells. So moving insulin, moving glucose from blood to the cells and tissues. So insulin responsible for regulate blood glucose. Okay, what type of product we have regarding the insulin? We have insulin given subcutaneous injection. We have insulin injection. We have insulin given inhalation as inhaler or available like intravenous. We have insulin pump and oral. Okay, we don't have oral. Oral will be destroyed by the GI enzyme, gastrointestinal enzyme. So it's not available oral. So currently we don't have oral insulin, but we have subcutaneous injection, we have inhalation, we have question mark about bioavailability, intravenous IV, and we have pump. And this one like programming pump, no need to do blood test to monitor insulin for the 24-hour. For subcutaneous, this one for chronic use. Intravenous, we prescribe insulin IV in emergency case. You can see it here in emergency case. We have insulin pump. Okay, let me type something here to maybe share it with you. We work with you together to. Okay. So you can see the insulin pump here, and like programming insulin pump. And this pump produce insulin according to the body requirement, and this insulin pump measure the blood glucose 24-hour and provide with the insulin according to the glucose level on the blood. Then for the insulin inhaler, it's not popular in the practice. Insulin inhaler. but it's not popular in the practice. The most popular one, subcutaneous injection. Okay, so what we have, this is a subcutaneous injection, small syringes, use it for the insulin. Okay, so now we have three maybe main route of administration: subcutaneous, number one; number two, intravenous; number three, insulin pump; inhalation, very rare; and the last one, oral, is not, we don't use it because we'll destroy in the GI system or with the enzymatic pathway. Adverse effect: if you prescribe insulin to your patient, there is a risk of hypoglycemia. We are on the agreement for that. They found that insulin may cause weight gain, increase weight. Insulin, if you inject insulin the same site repeatedly, this will lead to lipodystrophy, and this will lead to the maybe the skin reactions at the site of injection, lipodystrophy. That maybe we recommend patients to rotate the injection every time they inject. They try to change the place, not the, where they inject the insulin. Try to rotate the injection. Diabetic with a renal insufficiency need to decrease dose of insulin, so those should be adjusted in patient with a renal insufficiency due to the potential of bronchospasm. Inhaled insulin is not recommended. So if the patient suffers from asthma, COPD, which stands for chronic obstructive pulmonary disease, inhalation insulin is not recommended. Contraindication. Now we have two contraindication: oral contraindication because insulin will be degraded in the GI enzyme; inhalation contraindicated in asthma. When you injected the subcutaneous, the insulin may cause lipodystrophy. We recommend patient to rotate the injection from time to time. If the patient suffers from renal insufficiency, we recommend patient to adjust the dose and or decrease the dose according to the creatinine level. Weight gain, this to take this in consideration because we have two group of medication. Some maybe a group decrease weight, cause weight loss; another group cause weight gain. We have a group of medication cause hypoglycemia. So remember that insulin cause weight gain, increase weight, and may cause risk of hypoglycemia, which means decreased plasma glucose. This will lead to the serious side effect and could be coma and death. Insulin preparations, we need to look on the insulin onset of action, peak duration, peak of action, onset of action, peak of action, and duration of action. So we have several websites here. We can click on the first one. We look on the website. This is coming from the CDC, Center for Disease Control and Prevention, about type of insulin according to that time, time for the onset of action, peak, and duration. They have several category. We have it like rapid acting, we have short acting, we have intermediate acting, then we have long acting, the last one ultra long acting, then we have pre-mixed. I will repeat it: rapid acting. So we have several type of insulin. We have rapid acting, we have short acting, okay, then we have intermediate, then we have long acting, then we have ultra long acting. Okay, go back to the slide again to see what we have there. Okay, next one, Merck manual. This is very important, I think, to look on the website. Look on the data. This is a newly published data, not like from old textbook or something like that. So what they have there, you can see they have different category for the human insulin preparation. For example, we have rapid acting. Okay, we have Lispro, Aspart, Gloricine. Rapid acting start after, when you inject this insulin, it start after 5 to 15 minutes and remain in the body for 3 to 5 hours. The peak will be 45, 75 minutes. We have inhaled regular insulin is also very rapid. For short acting, the only one short acting here, we have regular insulin. So you can see here that when you prescribe regular, take 30 minutes, peak 2 to 4 hours, and remain for 8 hours. This medic may be regular. We prescribe it every 8 hours to the patient. Intermediate insulin, we have insulin isophane or isophane, insulin isophane. The peak between 4 to 12 and lasts for 18 to 24 hours. Long acting, we have glargine, we have Detemir, we have the Glinides, and you can see here the duration of action 24 hours. The most important one, we have no peak. This is the most important maybe characteristic of long acting. We have no peak, but take time to start working. You can see here, for example, glargine long acting, when you inject insulin to your patient, need 3 to 4 hours to start working. So you can imagine now the patient in emergency room, we cannot prescribe this medication to your patient because this take like 3 to 4 hours to start working. Okay, moving to the next website, to Semantic Scholar. This one, I think, will be answer some questions for us. I like what we have here in the slide. This is profile of a human's insulin and analog. You can see here for the glargine, the white curve, we have no peak. White curve, we have no peak. We have rapid, aspart, lispro. Then we have regular. Then we have intermediate, MPH. Okay, so we have different type of insulin according to the graph or according to the onset of action, peak, and duration of action. Okay, now we try to summarize in like Pramlintide. Pramlintide insulin usually taken a short time before meals. So this is before food, before the patient take the meals. We have short acting and rapid acting. So this medication prescribed before meal. Please remember that, Pramlintide insulin. So we have regular, then we have short acting. So we have two types of insulin. Regular short acting should be taken before meals, and they start working after maybe they said like what we have here, 15 minutes, 15 minutes, 30 minutes, 15 minutes. So most of these medication work maybe quickly, between 30 minutes, between 15 to 30 minutes. Most of these medication short acting. So for the rapid acting, we have lispro, we have aspart, glucosidase, we have inhaled. So we have 4 types: lispro, aspart, glucosidase injection, subcutaneous injection. We have inhalation regular, and you can see this medication start working after 15 minutes. For this reason, it's very good to use it before food, before the meal. Before you take the meal, you take the insulin, then we take the meal, and they control the blood sugar. Peak 1 to 2 hours, maybe remain to 3 to 4 hours. Okay, for short acting, we have regular, start maybe 30 to 1 hour, 30 minutes to 1 hour, remain 2 3, and duration peak to 2 3, and duration 4 to 6 hours. So now we remember which of these medication prescribed like usually before meal, short time before meal. We have short acting regular, rapid acting lispro, aspart, glucosidase. Okay, now we have another group of insulin called basal insulin, usually taken between meals, at bedtime, before sleeping. We have intermediate, we have long acting, and other maybe a group of medications they said ultra long acting for the Glinides, because you can see the duration here. So what we have here in this slide, for intermediate, we have NPH, neutral protamine insulin, humulin N. So the onset of action 2 to 4 hours. This is take time, so we cannot use it in emergency case. Okay, it's not allowed to use an emergency case because this take time, 2 hours, 4 hours. If the patient arrived to the hospital with the emergency case, we need something to work quickly, we go with the regular insulin for the emergency case. Okay, this medication remain between 16 to 24 hours. Long acting, we have glargine, Lantus, brand name, This medication start after 2 to 3 hours, and peak, we have no peak. The same apply here, no peak. Okay, moving to the duration, you can see duration 24 hour, and the last one 30 to 36 hour, ultra long duration of action. Okay, so now we have four main types for the insulin: short acting, rapid acting, MBH, intermediate, long acting. Okay, I will repeat it: rapid acting, short acting, postprandial. Then we have intermediate, long acting. Okay, which of these medication we need to fill this table here? We need maybe insulin, you consider like short duration, rapid acting. What we have to put here? What do you think? In this field, what we have to type there? What type of insulin? Short acting, rapid acting, short and rapid. 15 minutes or less. Okay, insulin Lispro, insulin Aspart, or insulin Glucosidase. What about the short duration? Okay, long acting, release insulin over extended period of time, prolong hypoglycemic, no peak. Remember we typed no peak somewhere. I will go no peak to look what we have. No peak. So what medication we have for no peak? Insulin glargine, Ditimer, degluted. So we go back. So we have insulin glargine. Okay, no peak. We have insulin glargine, Ditimer, and degluted. Okay, next we're looking for the medication short acting, short duration, slower acting, most commonly used for the IV emergency. Here this remind us with the regular insulin. Okay, what about intermediate acting? Should be given only subcutaneous. Number one, never IV. So we don't use it in emergency. We don't use it in emergency here. Okay, not for emergency. Should not be used for the rapid glucose lowering needed, such as emergency ketoacidosis or something like that. So we have MBH insulin or isophane insulin. Okay, we have some pre-mixed insulin. You can see it here like 30-70, 75-25, 30-70, 70-30. You can see what we have here: aspart, protamine, aspart, protamine sulfate, intermediate with aspart, ultra short, Lispro, protamine, MBH regular. So we have so many types of pre-mixed insulin, and this provide two things. Now, number one, to provide rapid onset of action and long duration of action. So with the premix, we have maybe we achieve two goals. Number one, achieve rapid onset of action and longer duration of action. You can see 24 hour. This medication start working in 10 to 15 minutes, and this will be great. And one injection per day. Okay, so we're done with the insulin. We spoke about the beta Langerhans. We spoke about how the insulin work, released to the circulation. Roughly, we cover all the information about the insulin. Okay, so we cover the insulin mechanism of action, insulin release, and which channels or which ions responsible for releasing of insulin. We spoke about the glucose transporter. We spoke about the potassium channels and calcium channels. We spoke about the ATP metabolism. That is important, and we mentioned mentioned the insulin action by controlling the liver and the blood, the muscles, for the blood glucose and regulate blood glucose. Moving to the side effect that may include hypoglycemia, weight gain, and lipodystrophy, and other maybe side effect. And then we discuss the preparation available for insulin, like rapid action, short action, intermediate, and then we have long duration of action. Okay. Okay, so we done discussing with the discussion of insulin. We move to the next injectable drugs used to treat type 1, type 2 diabetes. We have synthetic amylin analog. We have the product name, generic name, Pramlintide. The Pramlintide here, and you can see the brand name Similin. We know that amylin is like hormones produced from beta cells following food intake. The action of amylin delays gastric empty and improve satiety, decrease prostaglandin glucagon secretion. So decrease empty of stomach, decrease glucagon secretion, improve satiety. So three main action for the amylin. So we have medication available in the pharmacy and maybe in the practice. We have it Pramlintide, injectable medications. This medication used subcutaneous. Okay, so this medication used for two types of diabetes, type 1 and type 2 diabetes, who fail to achieve desired glycemic control on the insulin therapy. So the first step will be you prescribe insulin to your patient. So if the response failed, we move to the Pramlintide. So then the next option here. And another maybe precaution we need to be taken when we start Pramlintide, the dose of insulin should be decreased by 50% to avoid hypoglycemia. So there is a risk of hypoglycemia because the patient already on insulin and we add Pramlintide. So when you add Pramlintide, you have to decrease the dose of insulin to 50% to avoid hypoglycemia. Please remember this key word for the Pramlintide. Okay, adverse effect, patient may suffer from nausea, vomiting, and anorexia. Pramlintide should not be mixed with the insulin with the same syringes. It should be avoided in patients with diabetic gastroparesis, which means delayed stomach empty, and should be maybe aware about or notify your patient about the risk of hypoglycemic effect. So gastroparesis means delayed the empty of stomach, and the medication cause delay empty of the stomach. For this reason, it's not allowed to prescribe to the patient suffer from diabetic gastroparesis. Synthetic amylin analog. We have Pramlintide. Okay, so we're done with the first group of medication. We discussed insulin with you. Then we went to the Pramlintide. Then we have GLP-1 agonist now. Okay, so we discussed the first agent for the diabetes mellitus, insulin, Pramlintide. Then we have the third agent now, GLP-1. And this insulin will be most popular given like injectable, Pramlintide injectable subcutaneous, and GLP-1 injectable. We have one compound given orally, but most of the product for GLP-1 agonist prescribed like injections. So what happened here, they tried to explain what is this peptide for. We have glucagon-like peptide. So we have some introduction about this peptide before we go to the treatment with the GLP-1 agonist. They said that when you take oral intake glucose, this will lead to the higher concentration of insulin. Okay, so compare that with when you take IV. They look on the insulin level. They found we have less level of insulin. So they compare between oral glucose with the IV glucose. They found this one increased level of insulin in the blood. on the other hand, IV increased level of insulin in the blood, but not the same at the same insulin level in the blood, but not at the same level. So or they start asking research question: is there any reason why the oral glucose increased level of insulin in the blood more effectively than the IV glucose, for example? So we try to compare between IV glucose intake with the versus IV glucose intake between oral and IV on the effect of insulin secretion. They found insulin secretion will be higher after oral glucose. Later on, they found in the stomach we have hormones in the stomach, and this hormone called incretin hormones. So incretin hormones, we have two main hormones in the stomach. The first one called like a glucagon-like peptide, from the name GLP-1, glucagon-like peptide. This is the first hormone, and another hormone called the glucose-dependent insulinotropic (GIP) peptide. So these two hormones, when the patient take food orally, this hormone will be activated. So when you take food, arrive to the stomach, and the stomach start release the incretin hormone. Could be GLP-1 or GIP hormone. So what is the function of these hormones? So the incretin hormone responsible for 60 to 70% of insulin secretion after postprandial. So when you take food, okay, this process here, the incretin hormone responsible for secretion of insulin by 60 to 70%. So now we are familiar. We have peptide in our stomach responsible for insulin secretion called the GLP-1 and GIP. Okay, moving to what we have here, actions, how this maybe proteins or like glycoprotein work. They found this GLP-1, the action, they found improve insulin secretion. So number one, GLP-1 improve insulin secretion. Number two, slow gastric empty time. So they keep the food for a long period of time in the stomach. Slow gastric empty time. Number three, reduce food intake by enhanced satiety, feeling of fullness. So three things. Number one, improve insulin secretion, enhance insulin secretion, slow gastric empty, and reduce food intake by enhancing satiety or feeling of fullness. The other action, maybe important action, decrease secretion of glucagon and promote beta cell proliferation. So all these considered like important action for the GLP. Therefore, we have in the market now, we have some agent called GLP-1 agonist, stimulate this, mimic the effect of a GLP-1, glucagon-like peptide. We have list of medication. So what they found there, postprandial hyperglycemia is reduced. This is the action. This is a molecular, and this is maybe maybe clinical aspect or clinical action or beneficial effect. Decrease A1C, hemoglobin A1C, decrease weight, and reduce hyperglycemia. So we have three things: decrease blood glucose, control A1C, decrease weight. And we have very popular medication now in the market, Ozempic, and the brand name for Ozempic, semaglutide. The brand name, semaglutide. And again, we have another one, but not for diabetes. We call another one Wegovy semaglutide, but it's not for the diabetes. This one for obesity. Okay, so now we have two medication. This two medication considered like GLP-1 agonist, and popular name, brand name Ozempic, Wegovy, and the generic name semaglutide. Both medication given injection. Okay, so what happened here in general? You can see here. So we need to maybe remember all these action here about improve insulin, decrease glucagon, enhance satiety, slow empty of stomach, enhance cell proliferation. All these may be important action, mechanism of action. We have list of medication considered like glucagon-like peptide, GLP-1 agonist available. Most of them injection. The only one oral semaglutide, and the brand name Rybelsus, the only one available oral, Rybelsus semaglutide. Okay, so we have exenatide, Byetta, we have liraglutide, Victoza, dulaglutide, Trulicity, we have semaglutide, then we have mix between insulin and liraglutide, for example, or lexinatide. So we have maybe combination work between two medication here. Okay, as you can see here from the slide, this is the Ozempic semaglutide. It's available like 0.5 milligram pre-filled syringes, and we have it like 0.5 milligram or half milligram Ozempic. So if you click on the link here and look what we have. Okay, you can see the Ozempic here. The Ozempic, frequently asked question, all about drug being used for losing weight and available in two doses, 0.25 and 0.5. For the Wegovy, this one for the obesity, for reducing weight in an obese person. Okay, we start the first month, we start with the 0.25, second month with the 0.5, the third month 1 milligram per week, one injection per week, for 4 injection per month. So the box would contain 4 pre-filled syringes, and 1 milligram, start with the 0.25, 0.5, 1 milligram, 1.7 milligram, then 2.4. You can see from the graph here, we have escalating dose like stairs. Okay, so we have escalating dose, 25, half, 1 gram, 1 milligram, 1.7, and 2.4. So you can see the escalating dose for treating obesity. Okay, so we have the link here for the information for Wegovy. I'll click on the link. So you can see the graph here from the Wegovy, the pharmaceutical company producing Wegovy, and starting dose by 0.25 once weekly, and escalate the dose to the 2.4 milligram per day. Then we go from there. So it's around 17 weeks of treatment. Okay, GLP-1 receptor agonist. For talking about the GLP-1 receptor agonist, what we have here. Okay, for the GLP-1 receptor agonist, as you can see, this medication prescribed subcutaneous except Rybelsus. So if you go back to the slide, okay, all the medication prescribed injectable, only one medication prescribed orally, Rybelsus, and this one semaglutide. Okay, except semaglutide. This medication prescribed once weekly, for example, semaglutide, dulaglutide, abiliglutide. Short-acting once daily, we have liraglutide, for example, exenatide twice daily, short-acting. Then we have extended release once weekly. And we have the abbreviation here, information about this product. We can click on the link and for more information. GLP-1, then we have GLP-1 agonist adverse effect. So we already covered that. If you go back again to the slide, only to maybe recap what we have. We know this now. We are already familiar with the peptide released from the GI system in response to the oral intake of glucose. And this protein, we have two types of protein, glucagon-like peptide, GLP-1 GIP. Then we have a list of medication here. We talk about this list of medication, such as exenatide, semaglutide, and we discuss the action, effect on the glucagon, insulin, satiety, empty of the stomach, cerebral proliferation, and effect on the weight loss. So medication decrease weight, decrease A1C, and control hyperglycemia. Discuss the two medication available belong to the same product. GLP-1, how this medication prescribed, subcutaneous mostly. Now we talk about side effect. The side effect include nausea, vomiting, diarrhea, constipation, and pancreatitis. Talking about pancreatitis, this is 0.3%, and they said 3 per thousand. So if you treat 1,000 patients, maybe you are going to see 3 patients may suffer from pancreatitis. So the percentage here, 0.3%, this is not significant statistic data. So we accept this medication for practice. For example, so we still have maybe significant number, but if the number 0.05, this one to consider like significantly different between the placebo and the control. Here what we have 0.3, this number considered like important. Therefore, patient should be monitored closely to be sure he's not suffering from pancreatitis. So number one, pancreatitis, very important but rare. Okay, moving to the patient with a history of pancreatitis, this medication should be avoided. If the patient maybe this medication with the long-term use, they found this medication may be associated with the increased risk of thyroid C cell tumor, and this found in the animal, and it's contraindicated in patient with medullary thyroid carcinoma. So if the patient suffers from history of thyroid carcinoma, we don't prefer to prescribe this medication. So we have two cases here: thyroid tumor, thyroid carcinoma, and pancreatitis. It's not allowed to prescribe these two medications to the patient with the history of pancreatitis, history of thyroid cell tumor. Okay, go back again here. So I would like to click on this link here and read some information. This one about Ozempic. Okay, so together, so in rodent and animal, they found this medication may cause thyroid cell tumor. Number two, this medication may cause risk of tumor in the multiple endocrine neoplasia syndrome. Regarding the, let me minimize a little bit to read the information about this medication. Contraindication in patients with a history of thyroid carcinoma, hypersensitivity. Warning, if the patient suffers from history has been reported with pancreatitis. So all these may be considered like this medication may cause acute kidney injury. Okay, so moving to the what we have here, to the medication, we discussed the pancreatitis, thyroid cell tumor, rare, but it's like risk factors: nausea, vomiting, and diarrhea. Okay, percentage of medullary thyroid cancer. So we discussed the pancreatitis, 3 per 1,000. Other study they said is 2% of female and less than 4% of male patients may suffer from thyroid cancer. So if you click on this link here, say OK. And now the question: what is the percentage of prevalence of, for example, thyroid cancer due to the treatment with the GLP-1 or semaglutide? So I will type search of, I will type 2%. Okay, so you can see here thyroid cancer, generally speaking, is rare disease. Of all cases of thyroid cancer, medullary cancer is diagnosed in 2% of female and less than 4% in male patients. So you can see here the percentage like 2% and less than 4% in patients. Okay, now we try to focus on the major things here for the medication. Glinides, for example, here we have Glinides extended release, Victoza, then we have Trulicity, dulaglutide, Ozempic, Rybelsus oral, The important things here to look on the, for example, Victoza and Ozempic, all these group of medication, Ozempic with or without food, without food, there's a flexibility for the patient. Um, uh, Again, Victoza is the same, apply. Uh, but the important issue here for the group of medication, this three group of medication here, for example, no need for renal adjustment. If the patient suffers from some renal impairment or something, no need to adjust the dose. It's very important things. So you can prescribe it, save it to the patient. So Ozempic, Trulicity, Victoza, Liraglutide, Dulaglutide, Semaglutide, no need to adjust the dose in patient with the renal disease. This is number one. Number one, no need to adjust the dose. Number two, the important one. Number two. So we have two facts about the GLP-1 agonist. Two facts. Fact number one, no need to adjust the dose. Number two, could be taken with or without food, no interaction. Number three, and this is the important one, they found this medication provide benefit for renal failure, CKD, and this medication provide benefit for the cardiovascular disease and reduce risk of death. So you can see here this medication provide beneficial effect in patient with the CKD and patient with the cardiovascular disease. So we need to remember that this group of medication, especially Ozempic or semaglutide, Trulicity, Dulaglutide, Victoza, provide benefit for the CKD and for the heart disease. Cardiovascular disease prevent from death from cardiovascular disease and slow progression or prevent from maybe deterioration of chronic kidney disease. Okay, GLP receptor agonist and cardiovascular outcome trials. I will click on this one here to read information. Okay. So they tried to explain to us what happened or the mechanism of action. This is a website that present this information for the GLP effect. So you can see the cardiovascular effect here. They said the study demonstrate GLP-1 like semaglutide, Victoza, Ozempic has anti-atherosclerotic effect, increased endothelial function, decreased oxidative stress, anti-inflammatory effect, decrease risk factor of maybe for example LDL triglyceride, and decrease injury size such as infarction site. So all these like belong to the effect or beneficial effect of Ozempic, semaglutide, and liraglutide. Okay, the same. This one where the article published in Science Direct, GLP-1 receptor agonist and cardiovascular outcome trial and update. You can see here, this is a graph here. If you look on this, the image, we already prescribe this or demonstrate or present this picture for you on the screen. Okay, so there's a great benefit for the cardiovascular outcome, renal and cardiovascular outcome for the GLP-1 agonist. Please remember that. Okay. So we already covered the medication used for the diabetes that given injectable. I will repeat it. We have insulin, then we have amylin agonists such as Pramlintide, then we have GLP-1 agonist. Okay, so we have three group of medication prescribed as injectable product. We done with this one. So we move now to the next group, oral glucose lowering agent or oral hypoglycemic agents. We have less of medication. So number one, we have here Metformin, Sulfonylurea, Meglitinide, DPP-4 inhibitor, Dipeptidyl peptidase inhibitor, alpha glucosidase inhibitor, Thiazolidinediones, sodium glucose transporter inhibitor. Then we have combination of treatment. So you can see here we have list of medication. The first on the list, metformin, sulfonylurea, meglitinide. Sulfonylurea, we have some medication here. We need you to maybe familiar with this name: glipizide, cliboride, meglitinide. We have nitagliptin, ribaglinide, DBB4 inhibitor, sitagliptin, linagliptin, sixagliptin, alpha glucosidase inhibitor. We have acarbose, miglitol. Moving to the thiazolidinediones, we have here the bioglitazone, rosiglitazone. Then we have SGLT inhibitor. We have empagliflozin, canagliflozin, dapagliflozin. We have combination treatment. So we have list of medication we are going to cover in the next coming slides. So this medication oral. So what we can see here, we have two main group: injectable lowering agent, then we have oral lowering agents for type 2 diabetes. So what we have here, this is a category and the classification we need you to be familiar with. Metformin, this is a immediate release. Then we have metformin extended release, and this metformin belong to the Biguanide. That's great. Sulfonylurea, so they said the second generation, the most popular use. We don't prefer to use first generation, therefore we are not going to discuss the first generation. Second generation, glimepiride, glipizide, glipizide XL, cliboride. So we have a 4 medication in the list, but we have more than 10 belong to the sulfonylurea. Then on the list we have meglitinide, we have nitagliptin, then we have ribaglinide. Moving to another group. This is group number 1, group number 3, this is 4. We are talking about thiazolidinediones, bioglitazone, rosiglitazone. Okay, so moving to the next one, DBB4 inhibitor. We have allogliptin, linagliptin, sixagliptin, sitagliptin. So all these maybe prefix with the gliptin, ended with a suffix gliptin. Sodium glucose transporter inhibitor, we have canagliflozin, dapagliflozin, empagliflozin, ertragliflozin. All these ended up with the gliflozin, and this belongs to the sodium glucose transporter 2 inhibitor. Alpha glucosidase inhibitor, we have 2 medication, acarbose, miglitol. And less frequently used, we have some other medication considered like able to lower blood glucose, such as cholecalciferol. Dopamine agonists such as bromocriptine is very rare in the practice. Okay, we are going to stop here for the break. Then we come back to resume our lecture about diabetes mellitus. Okay, stay tuned.
Welcome back, everyone. After the break, we shall continue our lecture about diabetes mellitus. The first part, we cover the definition of diabetes. We went through the brief physiology of pancreatic cells. We spoke about alpha, beta, and gamma cells. We mentioned also the classification of diabetes. We have type 1, type 2, gestational diabetes, genetic diabetes. Also, we spoke about the complication of diabetes. We have 2 types of complication: acute complication such as ketoacidosis and hyperglycemia, severe hyperglycemia. We have chronic complication that include microvascular complication, macrovascular complication, neuropathy. Then we went to the maybe focus on the 2 main type of diabetes, include type 1, type 2 diabetes, and we mentioned what is the best approach for each type. Then we spoke about the pathophysiology of type 2 diabetes, mentioning that maybe the main pathophysiology related to the insulin resistance and or insulin sensitivity, in addition to the other maybe pathological process such as upregulation of sodium glucose transporter, for example. Then we went through the diagnosis of type 2 diabetes, mentioning the A1C, fasting glucose, postprandial glucose test. Then we spoke about the insulin physiology and the mechanism of action, how the insulin affect cells, how the insulin affect organs, muscles, adipose tissue. Then we spoke about the insulin preparation or product. We have short-acting, rapid-acting, intermediate, long-acting. Then we have ultra-long-acting. And the first one in the injection insulin. The second preparation was amylin, and we have one product in this group. We have Pramlintide, and then we mentioned and we discussed the GLP-1 with you, and to talk about semaglutide, liraglutide, Victoza, Ozempic, and other products. Now we are moving to the oral products, oral hypoglycemic agents. Okay, regarding the oral hypoglycemic agent, we already covered, I will go back again to show you that table there. So we have metformin, for example. Here we have sulfonylurea, meglitinide, dipeptidyl peptidase inhibitor. Then we have alpha-glucosidase, then thiazolidinediones, sodium glucose transporter. Then we have combination treatment. Okay, so we have here all the maybe products, and we already covered all these topics and mentioned the list for this medication, and we are going to discuss now every individual group of medication, focusing on the mechanism of action, clinical use, adverse effect, or contraindication for each group of these medication. We'll start with we're going to start with the first group of medication, sulfonylurea, and sulfonylurea mostly used in clinical practice as a second generation. We have first generation and second generation, and the most popular use for second generation, we have glyburide, glipizide, glyburide. This is the most popular medication used in the practice, glyburide, glipizide, glyburide. How this medication work? This medication considered like insulin secretagogues, that mean increased secretion of insulin. Okay, so by the increased secretion of insulin lead to the stimulate release from beta cell from pancreas, black potassium channel dependent on the ATP, and cause depolarization, allow calcium to influx to enter the cells and cause insulin exocytosis. This is the mechanism here. So if you go to the next slide, they show us how the sulfonylurea work. So you can see here sulfonylurea block potassium channels. By blocking potassium channel cause depolarization. Depolarization mean action potential, stimulate beta cells. This is beta cells in the pancreas. Stimulate beta cells. This will lead to the opening calcium channels. Opening calcium channel will lead to the increased concentration of calcium inside the cells. By increasing concentration of calcium, this will dig on the vesicles, on the insulin vesicles, and inside the vesicles we have the insulin here, and this will allow these vesicles to come to the cell surface, engulfing in the cell surface, and release the content of insulin to the blood. Okay, now we understand the mechanism of sulfonylurea. Sulfonylurea increase release of insulin. Okay, I will back to the slide. So this is the exocytosis, increase release of insulin. What about is there any side effect for this medication? Glyburide, glipizide, glyburide. Any side effects? For example, this medication, because we have increased level of insulin, this medication carry the risk of hypoglycemia. I think we are on the same page, me and you, because increased level of insulin, there is a risk of hypoglycemia. This is number one. Because increased level of insulin, we have a risk of hyperinsulinemia. This associated with the increased level of insulin in the blood. So number one, hypoglycemia. Number 2, hyperinsulinemia. Patient in this group may suffer from weight gain. So three main effects. Number 1, hypoglycemia. Number 2, hyperinsulinemia. And 3, weight gain. Okay, so the three main effects for the coming from the sulfonylurea. They remind us also the patient, if the patient has a history of sulfa allergy, we don't recommend to use this group of medication in this patient, because from the name sulfonylurea. So if the patient has a history of sulfa allergy, we don't recommend to use it. And as maybe to refresh your memory, we have several medication belong to the sulfa. For example, we have thiazide from the diuretic sulfa medication. Furosemide belong to the sulfa maybe chemical structures. What else? We have another medication called Bactrim. And Bactrim, we have in the Bactrim, it's like antibiotic, contain like sulfamethoxazole plus trimethoprim. So sulfamethoxazole here. So if the patient comes to the clinic has history of allergy to the sulfa or to the Bactrim, so here we need to remember and we need to know that Bactrim is type of sulfa. Therefore, if the patient allergic to the sulfa, this patient is not recommended or not allowed to use glipizide or any product from the sulfonylurea. Again, now we have three more popular medication belong to the sulfonylurea, but they said if the patient suffer from renal impairment, here we have to look on the renal function, is particular problem with the Glipizide. So if the patient has any problem with the renal or kidney, so this will be increased duration of action of Glipizide and increased risk of hypoglycemia. So the situation here, the best option, we have two options here. Number 1, to adjust the dose. So we have two options. Number 1, adjust the dose of Glipizide. And number 2, we can switch to another medication. So we have switched to another medication here. What we mean switch, we have Glipizide and Glipizide. So we have three medication. We can switch to the Glipizide or Glipizide, safer to consider like safer in patient with renal dysfunction. Now we have option for patients suffer from patients suffer from renal impairment, and we don't recommend to use the Glipizide, and if we need to use it, we need to adjust the dose, or we can switch the medication to the Glipizide and the Glipizide. Okay, so we already discussed the sulfonylurea as a first product in the oral hypoglycemic agent. Next group of medication, we have Glinides, Ribaglinide, Netaglinide. For this medication here, we have Glinide, and Glinide, Ribaglinide, Netaglinide. Also, this medication increase release of insulin. So consider like insulin significant, increase release of insulin. And you can tell me there is a risk of hypoglycemia, and there is a risk of hyperinsulinemia, for example. So this so increased stimulation of insulin. There is a risk of hypoglycemia. Okay. What else? This medication, what is the maybe advantage or the characteristic or the comparison between Glinide and sulfonylurea? So similar to the sulfonylurea, this medication similarity, if you put like a table here for like similarity and differences between a Glinide and sulfonylurea. Okay, both of them increase insulin. Both products increase insulin, number 1. Okay, in contrast to sulfonylurea, rapid onset of action, short duration of action. So rapid onset of action and short duration of action. Could be here medium to long. Okay, duration of action here. What else? Sulfa allergy history. Sulfa allergy. No risk of allergy. Okay, no risk of sulfa allergy. You can see it here. Glinide should not be used in combination with the sulfonylurea. Very important issue here. we don't recommend to use two medication work with the same or similar mechanism of action. Glinide work on the enhanced insulin release, sulfonylurea enhanced insulin release. Therefore, we don't recommend to use two medication work on the same mechanism of action. Okay, well, similarity for the group of medication, both medication increase weight and increase risk of hypoglycemia. So there is a similarity for this medication here. This medication increase weight and there is a risk of hypoglycemia. This medication is the same, increase weight and increase risk of hypoglycemia. So you can see here we have similarity between Glinide, Ribaglinide, Metaglinide. Okay, let me go there and type some medication, bring it to you. Okay, this is a Ribaglinide. So, for example, we can click on one of these products here, Ribaglinide. Okay, this is a Ribaglinide tablet. Okay, we have several products, Ribaglinide tablet. Okay, so Ribaglinide from the name belong to the Glinide products, work on the increased release of insulin from the pancreas. Okay. So this is the second group. So we covered the first one, sulfonylurea, the second one, Glinide, and we discussed the differences between Glinide and sulfonylurea. Moving to the next group of medication. Okay, Metformin. Metformin is medication belong to the Biguanide group and the only one in this group, Metformin. Metformin belong to the Biguanide group. Metformin, how the medication classify or work. Metformin increase insulin sensitivity. So consider like insulin sensitizer. So metformin is classified as insulin sensitizer. Increase cells and tissue sensitivity towards insulin, number one. Number two, metformin increase glucose uptake by the target tissue. So metformin decrease insulin resistance. So number one, increase sensitivity. They said according to this one, they found like decrease resistance. Metformin does not promote insulin, therefore we don't have risk of hypoglycemia, because when you have insulin we have risk of hypoglycemia, and metformin does not increase release of insulin, therefore we don't have risk of hypoglycemia. This is a good point for the metformin, number one. Off-label use, we don't have it on the prescription. We are going to see the prescription. This is off-label. That means it's not approved, but it's in the clinical use. This is due to the agreement between the physician and the patient, and they found metformin is also useful in the treatment of PCO, polycystic ovary disease, as the reduced insulin resistance seen in this disorder. So what we have here, we have with the PCO, polycystic ovary disease, associated with the insulin resistance, and our medication here, metformin, increase insulin resistance and may use to treat PCO or polycystic ovary disease syndrome. So this is a brief description about metformin. So insulin sensitizer, decreased resistance, no risk of hypoglycemia. Some study indicate it could be used for polycystic ovary syndrome. We have two new articles talking about the increased longevity or increase, consider like metformin as anti-aging drugs, increase lifespan. We have two articles, and I believe we need to speak in separate lecture about metformin and as anti-agent. Okay, metformin, how the metformin work? They found metformin work on the liver. Okay, metformin work on the liver by metformin decrease production of glucose from the liver. This is number one. Decreased production of glucose from the liver. Slow intestinal absorption of glucose. So we have glucose here coming from the food, and this one will be slow absorption of glucose from the GI system. Enhanced insulin sensitivity from in peripheral tissues such as muscle, because we need a glucose for these tissues. Okay, so we have three main mechanisms. Number one, decrease hepatic production from the liver, hepatic glucose production, slow absorption of sugar or glucose from the GI system. This may explain why metformin, some study they said decrease weight, some study, but other study they said there's no major effect on weight. It's like they prescribe it like neutral effect. Okay, no, we don't have increase or decrease. We have neutral effect on the weight. They said positive effect. Some study, other study, they said neutral effect on the weight. So it's very important to remember this one. I repeat it: decrease production of glucose from the liver. Number one. Number two, the slow absorption of glucose from the GI system. Number three, increase insulin sensitivity in peripheral tissues, and this will lead to maybe these information here will lead to the positive or neutral effect on weight. Okay, the American Diabetic Association recommend metformin. Okay, the first choice for type 2 diabetes, and then we have a question mark here. Question mark we already covered in the previous, maybe in the first part, according to the situation here. So what that mean, we need to look on what the patient, for example. So what we have here, we have patient, and this patient only suffer from diabetes only. We have patients suffer from diabetes plus obesity. Another group of patient suffer from diabetes and heart failure, and diabetes plus atherosclerotic cardiovascular disease. Then we have another one, another patient suffer from diabetes and should be here. Have to clean this one. They don't allow me to clean it. Okay, now it's working. Okay, CKD. So we have the situation here, depends on the patient. Only diabetes. Okay, the drug of choice will be here metformin. Okay, metformin for any patient suffer from only diabetes without any comorbid disease. Diabetes with obesity, we have different approach. Heart failure, atherosclerosis, CKD. For this one here, for example, here we talk about SGLT2 or like GLP-1 according to the new recommendation guidelines. Obesity, for example, we speak about the GLP-1 like Wegovy and Ozempic, and then we go with the other medication, empagliflozin, SGLT2. So now we have different approach according to the situation. Therefore, we need to remind ourselves. Depends on we are dealing with patients. So this is important maybe approach here. Depends on what we have. Okay, patient only with diabetes. Diabetes with obesity, diabetes with heart failure, diabetes with a cardiovascular risk factor, or diabetes with CKD. And I will remind you to go back to the article, and I will share with you the picture from the guidelines. What is the approach? What is the ideal treatment for the situation? Okay, moving back, here what we have. This is correct for the normal, for patient with diabetes only. Metformin may be used alone or combination with other treatment. Very popular to use metformin with other medication. For example, metformin plus sulfonylurea, metformin plus empagliflozin, metformin plus gliptin. We have several maybe combinations product belong to the metformin. Okay, how the medication work? As you can see, metformin mechanism of action. Metformin work on on the liver. Main action, activate enzyme in the liver, activate, please remember that, because we are dealing with a lot of inhibition, activation, blocking, whatever. So metformin activate enzyme in the liver. This enzyme called protein kinase, AMP, adenosine monophosphate dependent protein kinase in the liver. AMP activate, I will type here plus, activate enzyme in the liver, and this will lead to the inhibition of, okay, inhibition of glucose production. So what we have here, the inhibition of a glucose production from the liver. What we have, other action, they found the metformin enhance, increase glucose uptake from the tissue, especially when we speak about muscles. Increase insulin sensitivity, increase fatty acid oxidation, and decrease absorption of glucose from the GI system, glucose from the intestinal system. So we have this process here: activate enzyme, decrease gluconeogenesis, and decrease glucose production. This is a mechanism of action of metformin. So we need to be familiar. This is the main mechanism, primary actions. This is a primary action, but we have other action for the metformin. And we can go in depth also about speaking about oxidation. This is a very important issue. Okay, takeaway point. I think this is the main point should be focused on, okay, for the metformin. So what we have here, number one, increase insulin sensitivity in peripheral tissue. This is a key word. Metformin, increase insulin sensitivity. Metformin, first-line therapy for type 2 diabetes, and we discuss with you which group of diabetes considered like first-line therapy. Okay, another advantage, there is a no or low risk of hypoglycemic risk. So there is no or low hypoglycemic risk. Number three, or next, we have positive or neutral effect on weight. Remember that we discussed that sulfonylurea increase weight. Sulfonylurea increase weight. Glinide increase weight. Okay, metformin. Okay, they said neutral or decrease weight. And this is the advantage here, because with type 2 diabetes, patients suffer from obesity. So this medication considered like a drug of choice for newly diagnosed patients. Tolerance and side effect profile is considered maybe safe, low cost, cheap if you compare with other group of medication. Another important one, they look on the A1C, hemoglobin, glucosated hemoglobin, decrease A1C and the percentage 1.5 to 2% in new diagnosed patient. When you have patients suffer from diabetes, they decrease A1C by 1.5 to 2%. Also, they found they decrease triglyceride and LDL cholesterol. And another option, they increase HDL. So they believe that the metformin has a positive effect on the lipid profile, decrease triglyceride, decrease LDL, and increase HDL. But the percentage here is still small. So here the question, can I use metformin to treat patients suffer from hyperlipidemia? The answer, no and yes. No, when you're patient, we don't use it for hyperglycemia. Okay, so I will clean this one here and answer the question. Can I use the metformin to treat patient with hyperlipidemia? No and yes. No, for example, if the patient suffer from mild or like moderate to severe hyperlipidemia, here we need to place the patient on statin. Why? They said statin decrease lipid by 50%. So do you think statin is more effective and maybe controlling lipid? Yes, 50%. Here we're talking about 8% or 2%. So it's not enough to control hyperlipidemia. So for this reason, it's like metformin does not consider drug for the hyperlipidemia. But if the patient suffers from diabetes and with a mild elevation of lipid, metformin, they found metformin has a positive effect on the lipid profile. This is good. So LDL triglyceride 8 to 15%, HDL 2%. So take away point the important things about metformin: increase insulin sensitivity, first line for diabetes, low risk of hypoglycemia, positive or neutral effect on weight, tolerance side effect profile, low cost, decrease A1C 1.22%, and positive effect on the lipid profile. So all these consider like take away point of metformin. Metformin, okay, talk about ADRs. ADR stand for the adverse drug reaction, and could be a side effect. We don't prefer to use side effect. Adverse drug reaction, those related, those dependent. We are going to speak what that mean in the later on. So most commonly patients suffer from GI. So GI gastrointestinal, diarrhea, nausea, vomiting, stomach upset. The reason here, if you remember, this medication decrease glucose absorption from the GI system. So the main side effect will be related to the GI, diarrhea, nausea, vomiting, and stomach upset. This number one. This medication decrease concentration, B12 concentration, decrease absorption of B12 from the GI system. So we have lower B12 with the long-term use. Therefore, we recommend patients to take B12 if they use metformin for chronic use or long-term use. We prescribe supplement B12. Rare but severe. You can see lactic acidosis. It's very rare side effect, but could happen. Some patients may suffer from lactic acidosis and severe illness, or if in patient with acute kidney injury or acute kidney disease. For this reason here, we don't recommend to use metformin in patient with the renal dysfunction due to the risk of lactic acidosis. And this is considered like a life-threatening case. And if you click on, we try to go to the slide. Okay. Give me 1 second. Okay. Okay, here we are. We have the information about lactic acidosis and metformin. The risk of metformin. Metformin considered like contraindicated in renal dysfunction due to the risk of lactic acidosis, and lactic acidosis considered like life-threatening side effect of metformin. Okay, so if the patient suffers from renal dysfunction or liver disease, we don't recommend to use metformin due to the lactic acidosis. If I click on the link here and share the link with you, this is related to the lactic acidosis. Okay, so we don't have I will let me do something here. Okay, so you can see here in the black box warning, they said lactic acidosis. Post-marketing cases of metformin associated with lactic acidosis have resulted in death, hypoglycemia, hypotension, and resistance bradyarrhythmias. So all these because of life-threatening death. You can see here result in death. So this is a serious, very serious side effect, or like warning from the metformin, to be careful and maybe vigilant about the side effect of metformin. Okay. So black box warning, as you discussed there with the black box warning, we have lactic acidosis. So if the patient suffers from renal impairment or hepatic impairment, there's a risk of lactic acidosis. Therefore, we don't use metformin. They said we have to be careful and monitor your patient if you have patient 65-year-old and above, because there's a risk of lactic acidosis. Topiramate, the same with lactic acidosis. There's a risk of drug interaction and increased risk of metformin. And someone may ask, what is topiramate? So I will leave a question mark here. What is topiramate? A radiological study with a contrast here. If you use any contrast like radioiodine for the X-ray or something like that, we don't recommend to use metformin, and we recommend patient to stop metformin before the radiological studies. If the patient undergo through the surgery or acute heart failure, we recommend patient to stop metformin or switch to another medication. If the patient suffers from excessive alcohol intake and there is a risk of lactic acidosis, all these considered like black box warning from the metformin. Number one, renal impairment. Number two, hepatic impairment. Elderly people is above 65. Drug interactions, very important here. Drug interaction, radiological studies, surgery, hypoxic state, and excessive intake of alcohol. So let me look on something here, and I click on this one again. That take you to the metformin again. Okay, so you see here topiramate. Okay. Risk factor of metformin, lactic acidosis include renal impairment, concomitant use of certain drugs such as carbonic anhydrase, such as topiramate, and age 65. So radiological studies. So we have all this information in the warning on lactic acidosis. I think it's very important to focus on. Okay, according to the information, as you can see here, what is topiramate? Someone may ask, what is topiramate? Topiramate is medication used to treat epilepsy and migraine. So this is an important issue here from topiramate, coming from NIH. Topiramate state beryl. Topiramate used to manage epilepsy and migraine, considered like second generation anti-epileptic drugs. Okay. So in this case, we cover the metformin. Metformin, we regarding the dose recommendation, we have immediate release metformin. Then we have extended release metformin. Immediate release metformin, we starting dose 500 milligram once or twice daily, and then we have other option to go with the 850 once daily. So we have two options: 500 twice daily, once or twice, or 850 once daily. Recommended dose is 1000 milligram twice daily. In this case, that means we have option to go with the 2000 milligram per day. Then if the patient suffers from GFR less than 30, we don't recommend to use this medication, and we already discussed the reason, because there is a risk of lactic acidosis. Okay, the metformin XR also included there. If the patient suffers from renal impairment, GFR less than 30, we don't recommend to use this medication. But for the XR, you can see here we have 500 milligram once daily, 1000 milligram once daily. No need for twice, because this one covers 24 hours. Okay, starting dose 500, 1000 milligram once daily. Recommended dose is 2000 milligram. So we have, as you can see, we have two types of metformin. Immediate metformin, 500, 850, once or twice daily. Recommended dose is 1000 milligram twice daily. Okay, again, switch to the metformin. This is maybe give the kind of adherence for your patient. Okay, compare with the twice daily. Here once daily. Okay. And this is number one. Number two, the advantage of long-acting adherence once daily. Number two, they said the advantage of long-acting. The advantage of long-acting here, I would like to mention that it coming like less side effect, especially talk about GI system for such as abdominal pain, nausea, vomiting, okay, or diarrhea. So you can imagine here. So which one I have to use? Okay, I will go with the long-acting XR because once daily, number one. Number two, less gastrointestinal effect. I think we covered the metformin, all the information about metformin. And you can see here we have several slides. Number one, metformin belongs to the biguanide. Metformin increase insulin sensitivity. Metformin decrease insulin resistance. Metformin does not have the risk of hypoglycemia when you use it alone, of course. Metformin, we have off-label use in polycystic ovary disease. Again, metformin mechanism of action, we have several mechanisms of action, mainly work on the liver. Metformin recommended first agent in some cases for treatment of diabetes. Metformin could be used alone or with other medications. And this one reminds us that the mechanism of action of metformin merely affect the liver but affect the GI system also. Takeaway point, we discussed takeaway point for the metformin, very important things. Okay, metformin side effect, we discussed the lactic acidosis as important one, and we mentioned the B12 and recommend patient to take B12. Okay, metformin, black box warning, renal impairment, hepatic impairment, topiramate, radioactive substances. Then the doses, advantage of long-acting compared with the immediate release. So in this case, we cover the metformin. Okay, so I would like to click on this link here to show you the combination of drug products. Okay. Okay, you can see here what we have in the study. We have several medication. You can see we have clibeneclamide with the metformin. Clibeneclamide, this one like belong to the sulfonylurea and metformin. Then we have bioglitazone and metformin. This is a combination. We have Janomet, we have sitagliptin and metformin. Great. We have saxagliptin and metformin. Then we have linagliptin and metformin, allogliptin, bioglitazone, canagliflozin and metformin, dapagliflozin and metformin. So we have several medication with a clinical use. We have triple fixed dosing also. We talk about 3 medication in 1 tablet, triple fixed combination. So we have 3 maybe combination. I have a separate lecture about the triple therapy medication for in 1 tablet for diabetes, already published. Okay, so we already mentioned we have combination treatment and for the treatment of diabetes. Okay, now we have like a quick question here to refresh our mind. Which of the following statements is correct about metformin? Number 1, metformin contains box warning due to the potential of increased myocardial infarction. Box warning, myocardial infarction. Number 2, metformin decrease hepatic glucose production. Metformin can use safely in patients with renal dysfunction. Weight gain is a common adverse effect. So can you tell us, for example, which one is the black box warning? What do you think the main one? You remember that? The main one for the black box warning will be lactic acidosis, and especially in patients with renal failure or liver or hepatic failure. This one is not correct. So we're looking for correct answer. Weight gain, metformin, they found metformin neutral or decrease weight. This one is not correct. Metformin can be used safely in patients with renal dysfunction. No. If the patients have from renal dysfunction, we don't recommend to use metformin. What they found here, according to the mechanism of action, metformin decrease hepatic production of glucose. You agree with this one? So I will go with this one here, correct. This is our correct statement here. Okay, so we're done with the first group of, I'm going to recap what we have. Okay, so number one, we already discussed with you. Let me go back. Okay, we discussed with you sulfonylureas. We discussed with you, okay, a Glinide. Then we move to the metformin. Now we have thiazolidinediones, bioglitazone, and rosiglitazone. Okay, so one. Okay, that means this medication work on the nuclear receptor on the nucleus and lead to the modulate gene transcription and control glucose and lipid metabolism. This will lead to the increased tissue sensitivity towards insulin. So now we understand how this mechanism, how this medication, two medication, bioglitazone, rosiglitazone work. Increase insulin sensitivity, do not promote insulin release, don't cause the hyperinsulinemia. This medication work on the receptor called PPAR gamma, responsible for regulate metabolism of lipid and glucose. The ADA, American Diabetic Association, recommend like bioglitazone as the second or third line for type 2 diabetes. First line will be metformin. First line will be, for example, SGLT2 first line inhibitor. So first line could be GLP-1, for example. So this is the first line. So second or third line will be bioglitazone, not the first line. Rosiglitazone less utilized due to the concern about cardiovascular event. They said increased risk of cardiovascular disease. So this is we mentioned maybe two medication in this group: thiazolidinediones, bioglitazone, rosiglitazone. How this medication work? By affecting stimulate or affect the receptor called PPAR gamma. This receptor lead to the gene transcription, control glucose and lipid metabolism. This medication considered like second or third line agent for the type 2 diabetes. Now we consider like third or fourth line for the treatment. Okay, any side effect? We talk about the risk of, we have risk of liver toxicity. Okay, liver toxicity. For this reason, we need to monitor the liver function. Weight gain. This medication increase weight. Now we have three medication increase weight: sulfonylureas. Then we have Glinides. Then we have thiazolidinediones. So three medication increase weight. Okay, so increasing weight, and they found this medication retain fluid. For this reason, it could be worse in heart failure because we have fluid retention. So if you maybe I refer you to the heart failure lecture to know that the maybe blood volume, increased blood volume, worsening heart failure, and we know from the equation. So I will prefer to maybe the audience to go back and listen to the heart failure lecture or read the information about heart failure. So worsen heart failure. Okay, number one. Number two, liver toxicity. Number three, they found in women there's increased risk of osteopenia and risk of fracture. Okay, moving to the bioglitazone, some study found that the bioglitazone increased risk of bladder cancer. Bioglitazone, risk of bladder cancer. Rosiglitazone, increased risk of myocardial infarction. So you can see here we have two major side effect related to the individual medication in the same umbrella. Thiazolidinediones. Bioglitazone increased risk of bladder cancer. bioglitazone. Rosiglitazone increased risk of myocardial infarction. Black box warning. If you click on the link here, okay. So what we have here, you can see we have rosiglitazone. Black box warning for rosiglitazone, Avendia. Okay, you can see exacerbate heart failure due to the fluid retention in general. All thiazolidinediones carry the risk of heart failure. Okay, moving to the second one. The second one here, what they found here, meta-analysis from 42 clinical studies. They found there, okay, Avendia or rosiglitazone associated may be associated with the increased risk of myocardial ischemia and myocardial infarction. So this is the important things about these two medications as a black box warning. So now I will repeat it. Heart failure for all thiazolidinediones. But for example, bioglitazone, risk of bladder cancer, rosiglitazone, angina, and myocardial infarction. Okay, this is a study maybe to focus on the rosiglitazone less utilized due to the concern regarding cardiovascular event, and we have seen that in the prescribing information for the bioglitazone Avendia. What they said, comparative cardiovascular event, systematic review, and meta-analysis. In the abstract, the objective there, they said among patients with type 2 diabetes using rosiglitazone associated with significantly higher congestive heart failure, myocardial infarction, and death. So this is related to the rosiglitazone. Okay, so this is a study published in British Medical Journal, and I'm going to click on this study here and show you what we have. And this is a link here, so I don't bring, or maybe okay. Okay, the study here, comparative effect of thiazolidinedione, and the conclusion here, among patients with type 2 diabetes, rosiglitazone associated with significantly higher of congestive heart failure, myocardial infarction, and death. So three things: congestive heart failure, myocardial infarction, and death, rosiglitazone. So for this reason, it's not clinical practice. It's not popular in clinical practice. We don't prefer to use rosiglitazone in the clinical practice due to the three things. Number one, myocardial infarction, heart failure, and risk of death. Okay. Okay, and next group of medication considered like hypoglycemic agent. We have alpha glucosidase inhibitor. We have two medication in this group. We have acarbose miglitol. Alpha glucosidase, we are going to maybe bring a brief physiology. Alpha glucosidase inhibitors are oral agent used to treat type 2 diabetes. They found this enzyme, alpha glucosidase, this enzyme available in the intestinal brush border. This enzyme available in the intestinal brush border. Why it's enzyme? Because we are speaking about ACE, alpha glucosidase. This is enzyme. This enzyme available in the intestinal brush border and responsible for breakdown of carbohydrate. The carbohydrate will break down into glucose and other simple sugars. Okay, so in this case, prepares the sugar to be absorbed to the blood. So we need this enzyme. So when you eat carbohydrate, this enzyme break the carbohydrate to the glucose and other simple sugar, and this will be absorbed to the blood and Now we have our medication inhibit absorption of this enzyme, inhibit this enzyme and inhibit absorption of glucose. Acarbose and Mellitus reversibly inhibit the alpha glucosidase enzyme when taken at the start of the meal. So this means before, when you start taking the food, you take this medication. They delay digestion of carbohydrate, result lower postprandial glucose level. So we recommend to take this medication maybe at the beginning of the food and decrease absorption of glucose from the GI system. Okay, the advantages for this group of medication. Advantages, we are speaking about this medication does not increase release of insulin, and there is no risk of, does not increase insulin release, and there is no risk of hypoglycemia. So two things coming from alpha glucosidase: no risk of the hypoglycemia because this medication does not stimulate this medication or these medications do not stimulate insulin release. Two medications, acarbose and Mellitus. Medication, because this medication mainly work on the GI system and the brush border of the GI system. Patient may suffer from diarrhea, flatulence, abdominal pain. If the patient suffer from like Crohn's disease, inflammatory bowel disease, or ulceration, ulcerative colitis, we should not be used these medications in those patients. Okay. Next group of medication, I believe it is an important group of medication, belong to the Dipeptidyl or Dipeptidyl peptidase 4 inhibitors. We have the most popular use. We have more than this 4 medication. The most popular use, we have sitagliptin, linagliptin, sixagliptin, and allogliptin. This medication prescribed orally, oral DPP4 dipeptidyl peptidase inhibitor, used in the treatment of type 2 diabetes. So you need to remember that this medication mainly used for type 2, not for type 1, and by inhibiting the enzyme called DPP4 enzyme. Okay, how this medication work? We already covered the incretin hormones that release from the GI system. They found this group of medication prolong activity of incretin hormone. This number one, reduce secretion of a glucagon. That's great. The weight they found may be neutral effect or decrease weight. That's great also. The medication here, if the patient suffers from renal dysfunction, need to adjust the dose in patient with renal dysfunction. Okay, so you need to adjust the dose in patients with renal impairment. Most common side effect, the most common nasopharyngitis, headache, all the group of DPP4 inhibitors cause this effect, nasopharyngitis, headache. One per 1,000, one person every 1,000 patient may suffer from pancreatitis. Severe and joint pain could be happen from DPP4. So you can see here pancreatitis, nasopharyngitis. So the most common, nasopharyngitis and headache. This is the most common things. Very rare pancreatitis, 1 in 1,000. Okay, severe joint pain. So we have, this is most popular maybe side effect about DPP4, how this medication work, and we have the slide here. Okay, for the example, for the linagliptin, one of the most popular medication, sitagliptin, most popular medication. So we have sitagliptin and linagliptin, sixagliptin. When the patient or when the individual take food and the food arrives to the intestinal or GI system, our intestinal will produce hormones called incretin. And we have GLP-1, we have GIB. If you remember, we already discussed that with you. Okay, this will activate GLP-1, and the GLP-1 will produce the action for example, stimulate insulin, increase satiety, delay empty of stomach. So all these action of GLP-1. Okay, but what they found later on, according to the research, scientific research, we have enzyme in our body called DPP4, and we discussed that, what that mean. If you go to the previous slide, linagliptin and sitagliptin inhibit, you can see the X here, mean inhibit. So linagliptin or sitagliptin inhibit this enzyme. So before we speak about the inhibit, okay, what is the function of this enzyme? As you can see, we have, when you take food, the food will release the GLP-1, the GLP-1 will produce action. So take food, produce the GLP-1, GLP-1 produce action. But they found in our body we have enzyme called DPP4. This enzyme responsible for inactivation of this protein. So this enzyme inactivate this protein. This one, inactive products. Okay, they produce, or they developed a medication belong to the DPP4 inhibitor. We have linagliptin, sitagliptin, sitagliptin. This medications here inhibit, this medication inhibit the enzyme, inhibit DPP4 enzyme. So what happened here? When you inhibit this enzyme, the result will be, okay, when you inhibit this enzyme, the result will be increase. This will lead to the increased availability or prolonged action of GLP-1. Okay, so when you inhibit this enzyme, the next step will be prolonged action of GLP-1 and produce more activity for this, for example, increased release of insulin. So we are going to speak the enhanced satiety. So we have it in the next slide. So this is a linagliptin and DPP4 inhibitor. You can see here the medication linagliptin decrease degradation of incretin hormone GLP-1 GIP. This will stimulate insulin biosynthesis and secretion, stimulate insulin, and decrease the glucagon level. So this is the two main actions. But we have other action. Two main action: increase insulin and decrease glucagon. And the result will be, what they said, linagliptin has dual actions, two main actions, to lower blood glucose and regulate glucose homeostasis. Okay, I will go to the image again and remind everyone, two main action: increase insulin, decrease glucagon, and regulate blood glucose homeostasis. Okay. I think we're done with the linagliptin. We covered linagliptin. I will go back again for the DPP4 inhibitor. So this is a group of medication. We discuss how this medication works by prolonged activity of incretin, reduce glucagon, reduce secretion of glucagon, neutral on weight. Patient with kidney disease required adjusted doses. Some most common side effect: headache and nasopharyngitis. Very rare pancreatitis. Severe and joint pain could be happen. We discussed how this medication work. Okay, moving to the main action, two main action: increase insulin and decrease glucagon. Okay, we're done with the linagliptin. So we need to remember how this medication work. Okay. So next we have next group of medication. We have sodium glucose cotransporter inhibitor, sodium glucose cotransporter 2 inhibitor. We have canagliflozin, dapagliflozin, empagliflozin, ertragliflozin. And you can see the suffix gliflozin. So we talk about gliflozin. Gliflozin here, the suffix gliflozin. Okay, this is oral agent given orally. We are going to bring some example how this medication work. This medication decrease reabsorption of glucose, increase urinary glucose excretion, and lower blood glucose. So this medication work on the kidneys, increase urine glucose, okay, decrease absorption of sodium and cause diuresis Okay, that will be great if the patients are from hypertension, if the patients are from heart failure. Okay, some studies they said this medication decreases risk of death in patients with cardiovascular disease. So you can see here we are going to discuss some information about that with you. Okay. So what we have so far here about the sodium glucose transporter 2, we have canagliflozin, dapagliflozin, empagliflozin, oral agent. This medication work on the cotransporter from the name, cotransporter in the kidney, okay, and decrease absorption of glucose, increase urinary glucose excretion, lower blood glucose. This is number one, lower blood glucose. Number two, decrease reabsorption of sodium, lower sodium, and for this reason, lower blood pressure and use for management of heart failure and decrease hospitalization. And the study found that the empagliflozin, for example, decrease risk of death due to the cardiovascular risk factor. Okay, the SGLT2, all these compounds, sodium glucose, they found may cause female genital mycotic infections, fungal infections, urinary tract infection, and urinary frequency and risk of hypotension. So if the patient's, for example, blood pressure normal, this medication may cause hypotension. Ketoacidosis has been reported with the using of SGLT2 inhibitor and should be used with caution in patients with risk of ketoacidosis. And this medication should be avoided in patients with renal dysfunction. Okay, so I would like to share with you a website to demonstrate the action of sodium glucose transporter and demonstrate how this medication works. I will click on the link here. Okay, I will say okay. I'll bring the picture for you, and this one from the website. Okay, so you can see the picture here about the sodium glucose transporter 2 in the kidneys, and we have, for example, here we have Invokana, some of the medication, for example, here, and this is you can see the nephron here in the kidneys, and we have proximal proximal tubules, and what we have, this is our target here, SGL2. This is a transporter. We have blood here, we have the cells, we have urine. So you can see this transporter responsible for bringing the sodium and the glucose from urine to the blood. So this transporter responsible for transport urine and glucose from the blood, from the urine to the blood. So our medication, you can see here, SGL2 inhibitors such as empagliflozin, canagliflozin, Invokana, or Jardiance. You can see or EMPA. So we can see here our medication inhibit this transporter. So what we have here, okay, I will go back to what we have. So this is a nephron. I will type this, like, if you go back to my lecture about diuretic, and this is the cells here. Okay, we have blood here, then we have urine, here we have cells. So what we have, if you go to give me 1 second. Okay, we have transporter, and this transporter should be here, and responsible for co-transport of sodium and the glucose from the urine to the blood. So this brings the glucose from the urine to the blood. Okay, our medication such as empagliflozin, okay, inhibit empagliflozin inhibit this transporter. Now we understand the mechanism. Empagliflozin inhibit the co-transporter. Therefore, we don't have, this will lead to the decrease. I will go with the blue one. type there. This will lead to the in the blood. What happened in the blood? Okay, decrease glucose in the blood. This will be great for diabetes, and decreased level of sodium in the blood, and this will be good for the heart failure and hypertension. And this one for diabetes mellitus, and we have to say type 2. So you can see now that why this medication considered like very good medication for patients suffer from hypertension, heart failure, type 2 diabetes. Okay, but we need to remember the maybe some side effect could happen, like genital mycotic infection, urinary tract infections, hypotension, ketoacidosis, and patient with renal dysfunction. We have to take maybe caution for that. Empagliflozin, as you can see, we need to remember which part of the nephron that will be affected. If you remember, we have proximal convoluted tubules. This is the first part of the nephron. Will be affected. Proximal BCT, proximal convoluted tubule, will be affected because we have the transporter there, and this medication work on that transporter SGLT2, and prevent reabsorption of glucose and sodium. Empagliflozin inhibit these transporter and the BCT in the kidneys and lower blood glucose. Okay, potential mechanism involved in cardiorenal benefit of empagliflozin, EMBA-REG outcome. I like this one here, and we are going to discuss that with you through the link, but this is a summary for the EMBA study. So for the EMBA study, what they found here, when you prescribe empagliflozin to your patient from the study published in Science Direct here, so we can look on the Science Direct, me and you together, when we're done with this list here. Empagliflozin, number one, the benefit, potential mechanism benefit for renal and heart and renal benefit of empagliflozin. Number one, from this study here, number one, decrease A1C, hemoglobin, glucosated hemoglobin, decrease weight. This is a very important effect. Decrease A1C, decrease weight, decrease uric acid. That's very important. Uric acid, decrease blood pressure. Okay, decrease blood volume. Osmotic diuresis for the hypertension. Sympatholysis. I like this one. Fuel energetic. Provide ATP to the cells. Provide energy to the cells. Okay, by shifting the source from glucose or fatty acid to the ketone use. So if someone interested in the ketone diet, this is the best option, because this medication switch the source of energy from glucose to the ketone. So switch the energy from glucose to the ketone. This is very important according to the study. Okay, another one important for us, sympatholysis. Sympatholysis here, need to go back and maybe discuss something with you for sympatholysis. Okay, for when you say sympatholysis, what that mean for us. So before we discuss sympatholysis, we need to be familiar what is sympatho mean. Sympatho, so this is belong to the sympathetic system. When you talk about sympathetic system, you are talking about epinephrine, norepinephrine, dopamine, and other main. This is the three main maybe mediator belong to the sympathetic system. Another name for sympathetic system, adrenergic system. Another name for epinephrine, another name adrenaline. So what do you think about this system here? If this system activated, what happened to the blood pressure? They said blood pressure will be increased. Blood pressure will be increased. What happened to the blood glucose? Glucose will be enhanced. What happened to the heart rate? So we have so many action for the adrenergic system. What they found, I will go back, the sympatholysis, this group of medication, like we talk about the empagliflozin. Empagliflozin here inhibit Empagliflozin inhibit sympathetic system, so decrease or control these mediator in our body. So now we understand the effect of sympatholysis here, what that means for the record. Okay, before we go to the next, I will close this one. I click on the link here. This is a EMBA rig outcome and the endocrinologist point view about EMBA. They try to explain the benefit effect on the heart, on the kidneys, on the adipose tissue, improving glucose for the EMBA. So potential mechanism involved in the cardiorenal benefit of empagliflozin. Multiple potential mechanisms belong to that. So what they found there, so this medication reduce A1C, reduce weight, reduce uric acid, hemodynamic effect. All these may be covered in our lecture. Okay. Another study published in Circulation belonged to the American Heart Association journals. They spoke about the benefit of okay, I will go back. The benefit of sodium glucose transporter inhibitor, the benefit in the deprivation, neutral deprivation signaling autophagy hypothesis. We can click on the link here, belong to the American Journal, and see what we have there. And this is full text. You can read the full text at your own time. And I will click on this one here. And this slide demonstrates the effect of sodium glucose transporter on the heart failure. And they found it's like beneficial in the prevention of development of heart failure. And we have several mechanisms by preventing worsening heart failure, worsening kidney function, and activate angiotensin II. All these lead to protection of developing heart failure and reduce risk of death. So with the link here, we recommend you to review the link and read more information about the maybe EMBA and heart failure. Okay. Now, comparative study, this source of information coming from JAMA, work.com, but we can read more information about that. So in this slide, we need to focus on for example, Jardiance, empagliflozin, canagliflozin, and Fucana. Then we have Ertra, then Forxiga. So you can see here what we have. We need to adjust the dose for all patients. Okay, we need to adjust the dose for your patient here. Canagliflozin, we need to adjust the dose. Not recommended if the GFR between 30-45, contraindicated less than 30. Empagliflozin, don't use it if the GFR less than 45. What we have in this slide here, we need to focus on the cardiovascular benefit, for the empagliflozin, canagliflozin, dabigliflozin, or dapagliflozin. You can see this medication affects the atherosclerosis cardiovascular disease, reduce risk of death. Okay, benefit heart failure and benefit in CKD. So we have three benefits: heart failure, CKD, atherosclerosis cardiovascular disease, and we can look on the JAMA articles. So what they said here, association of SGLT2 inhibitor with the cardiovascular kidney outcome in patients with type 2 diabetes. We can read the information, and I will jump to the conclusion with you, but at your own time you can read more information here. So what they found here, SGLT2 inhibitor were associated with the reduced risk of major adverse events, in addition to suggesting heterogeneity associated with the cardiovascular death. It's very important things here. Okay, so there is benefit from the heart failure, CKD, and cardiovascular risk factor and risk of death, decreased risk of hospitalization. Okay, I have to go back a little bit and we can share something with you. Okay. Okay, so before we go further to the next, because we almost cover everything now for diabetes, let me bring some information. Okay. Okay, I will share the screen with you about medication here. And this is about the empagliflozin Jardiance. Only we need to focus on the indication, empagliflozin tablet for use. And we have the indication here. I like the indication and uses. This medication reduces risk of cardiovascular death. Wow, and decrease hospitalization for heart failure and in adult with heart failure. So decreased death due to the cardiovascular disease, decreased hospitalization, reduced risk of death in type 2 diabetes, adjunct in adjunct to the maybe diet, exercise in patient with type 2 diabetes. So for this reason here, this medication considered number 1 in the treatment of type 2 diabetes. Okay, so we're done with the maybe discuss the agents. So we are going to speak with you about maybe more details about that. So as you can see from this table here, speaking about the maybe summary of the effect of medication metformin, is there any risk on the hypoglycemia? They said no. Risk of hypoglycemia, effect on weight, they said neutral or sometimes decrease weight. So we can go with this one like here. Potential benefit in the atherosclerotic cardiovascular disease, yes and no. Sulfonylurea, we don't recommend to use it because sulfonylurea increase weight, sulfonylurea increase risk of hypoglycemia, and sulfonylurea here they said neutral, and we have another study they said this is increased weight, not for the weight, the increased weight, but there's no effect on the cardiovascular outcome. Thiazolidinediones, no risk for hypoglycemia, but there's risk of increasing weight. Insulin increase weight. So if the question, which of these medication increase weight? So we have 3 medication here. We have sulfonylurea, we have thiazolidinediones, and we have insulin. We can add a Glinide. So increasing weight, sulfonylurea, thiazolidinediones, insulin, and the Glinide, increasing weight. Okay, moving to the risk of hypoglycemia. Okay, so risk for hypoglycemia. Okay, sulfonylurea, insulin, Glinide. Okay, risk for hypoglycemia. What about potential benefit for the cardiovascular disease? Potential benefit, we have 2 main maybe a group of medication. Potential benefit, we have sodium glucose transporter inhibitor, we have GLP-1 inhibitor, GLP-1 agonist, sorry. So what we have here, sodium glucose such as empagliflozin, canagliflozin, benefit the heart disease and decrease risk of death, and the GLP benefit like semaglutide, dulaglutide, liraglutide, benefit the heart. So benefit the heart, we have this group of medication. Metformin, potential benefit. We have so many studies about metformin and the potential benefit, but not like empagliflozin and semaglutide and dulaglutide. Okay, side effect, the cost of therapy, metformin, sulfonylurea, low cost of therapy. Talk about the, for example, GLP-1, Fictosa, or other medication cost like $1,000 per month. It's very expensive medication compared with other medication with a low cost. Uh, Side effect, this is important things. Side effect, we need to focus on the side effect. Metformin, GI, diarrhea, nausea, B12 deficiency, metformin. Sulfonylurea, weight gain, hypoglycemia, thiazolidinediones, edema, weight gain, risk of heart failure, risk of bladder cancer, DPP4 inhibitor, we have pancreatitis, joint pain. Of course, we need to remember nasopharyngitis. Okay, sodium glucose transport inhibitor. It's the expensive medication, may cause genitourinary eviction, may cause volume depletion, may cause hypotension, risk of amputation, bone fractures, especially with the canagliflozin. There's a risk of bone fracture, risk of ketoacidosis. GLP-1, GLP-1, because maybe we have to be careful about risk of thyroid cell tumor, and we discussed that. There is a risk of pancreatitis. Insulin carries the risk of hypoglycemia, weight gain, and injection site reaction. So all these very important, like summary of what we have done about the medications. So two tables summarize the information for us for the oral hypoglycemic and injectable. We have metformin, sulfonylurea, thiazolidinediones, DPP4 inhibitor, sodium glucose, GLP-1, insulin. And we look on the hypoglycemia. Which one cause hypoglycemia? Which one cause increased weight? Which one decrease weight? I like what we have here for decrease weight. So which one decrease weight? Decrease weight, sodium glucose transporter inhibitor and the GLP-1 decrease weight. Okay. So this one from the article published, and I'm going to look on the pharmacological approach to glycemic treatment. I will click on the what we have here. But what they said here, metformin is a preferred agent as initial pharmacological agent for the type 2 diabetes. Among patients with type 2 diabetes who have atherosclerosis, cardiovascular disease, kidney disease, and heart failure, this is great. So in general, metformin, drug of choice. But if the patient suffers from cardiovascular disease, heart failure, kidney disease, look what we have. Sodium glucose transporter. Okay, what about the GLP-1? Yes, agonist for the due to the cardiovascular disease benefit. Let us click on the link and read the information. Okay, this is a pharmacological approach to glycemic treatment, type 2 diabetes, 2020 American Diabetes Association recommendation here. Guideline development, so we can go through all these steps and more details, more information here about the situation, and we have new guidelines 2023 available now. So I recommend you to read this information, click on the link and read more information about that. Okay, I think this is the last slide about diabetes. The last slide about diabetes, gestational diabetes mellitus. So what happened here? This is the maybe diagnosed during pregnancy. Gestational diabetes happened during pregnancy here. Okay, so the gestational diabetes mellitus is diabetes diagnosed in the second trimester of the pregnancy that not overt diabetes. Human insulin, the drug of choice. So if you have pregnant women suffer from diabetes during pregnancy, so the insulin will be drug of choice. Please remember that. So drug of choice will be insulin, and we have the reason here. They tried to because they found insulin does not cross placenta. Okay, this is important one. Insulin does not cross placenta. What else here? Okay, number one choice, or first the drug of choice for the situation here will be insulin because unable to cross placenta. Metformin could be alternative to the insulin, and if we have declined insulin therapy, and we look on the inability to maybe to use the injection or the cost of therapy, Glyburide, considered also first-line therapy for the pregnant woman. This one, according to the recent study published about the insulin therapy and preventing neonatal morbidity. So what we have here, as you can see, we have three options. If we have pregnant women suffer from diabetes, drug of choice insulin. Number 2 would be metformin. Number 3 will be glyburide. But this is not correct order. Number 1, insulin, I agree with this one, but 2 and 3 is not correct because depends. Let me say we have pregnant women with the renal disease. Okay, with the renal, we don't recommend to use metformin because there is a risk of lactic acidosis. So we have to go with this one. We have pregnant women with obesity. And you know that glyburide increase weight. So for this reason, we don't recommend to use it, for example. So we have several maybe points should be taken in consideration before you prescribe your medication to your patient. We have some exercise question here. Which is the most appropriate initial oral agent for management of type 2 diabetes in patient with no other comorbid condition? The patient come to the clinic healthy, otherwise he is healthy, but he suffers from type 2 diabetes mellitus. Everything normal. Okay, he doesn't have hypertension or heart failure or arthritis or whatever. So he is like 52 years old and without any important history. Shall we go with the glipizide, empagliflozin, metformin, and bioglitazone? So if you choose metformin, will be the correct answer. Newly diagnosed patient with everything normal, no other comorbid disease. We don't have any other conditions. Metformin. Okay, which class of oral diabetic drugs is paired mostly appropriate with the mechanism of action? So we're looking for the appropriate mechanism of action. I will start with the first one. DPP-4 inhibitor, inhibit breakdown of carbohydrate. What do you think? Okay. Yes or no? Wrong. Okay. Sodium glucose transporter inhibitor, increase excretion of glucose, increase glucose in urine. Yes or no? What do you think? Increase excretion urine. Increase urinary excretion of glucose. Yes. Sulfonylurea, increase insulin sensitivity. Wrong. There's no effect on sensitivity. Thiazolidinediones, decrease hepatic gluconeogenesis. Wrong. So if you think about what is the correct statement here, which medication increase insulin sensitivity? Okay, metformin. What else? If you remember sensitivity, we have thiazolidinediones. Okay, which medication decrease gluconeogenesis? Which medication decrease hepatic gluconeogenesis? Metformin. Okay, now we try to answer here. Which medication inhibit breakdown of carbohydrate? Which medication? Acarbose. Miglitol. Okay, so we try to, when you read the question, try to analyze the question and try to figure out what is the best answer for each statement. In this case, they give you more information. So if I clean all these information here for us or for ourselves, okay, we're done. Okay, is that what we have here? This is the correct answer. Okay, mechanism of action. This is the correct answer. Okay, which of the following medication diabetes least likely to cause weight gain? Liraglutide, bioglitazone, ribaglinide, and insulin glargine. Insulin increase weight. Ribaglinide increase weight. Bioglitazone increase weight. Liraglutide, this one decrease weight. So this is the correct answer here. Okay, 55-year-old obese female, type 2 diabetes, 10 years. This is case study. Okay, type 2 diabetes for 10 years. She is currently being treated with metformin, but her A1C above goals, so it's not controlled. She has a history of heart failure and chronic obstructive pulmonary disease, COPD. Her physician would like to add medication that will not cause weight gain. Which of the following would be the most appropriate to control this patient diabetes? Okay, now we have obese, so we have weight, we have type 2 diabetes, we have heart failure, and the patient already on metformin. So what medication will be added to control the situation in this patient, because A1C above goal and she is concerned about weight, heart failure, whatever. What about insulin, inhaled insulin? If you said yes, I would say it's not correct, because what happened there, I will clean all these boards here, and I would like to say something here is important. It's not correct, because inhaled insulin will make the situation worse. The patient already suffer from chronic obstructive pulmonary disease. We don't prefer inhaled insulin, so this is not correct answer, for example. Number one. Number two, so we don't recommend because of COPD. Number two, because this patient suffer from obesity and insulin increase weight. So this is number two. Okay, so for this reason, inhaled insulin will not be the maybe good choice for this patient. What about bioglitazone? Okay, speaking about bioglitazone, if you review the slide back, they found that bioglitazone causes fluid retention, and for this reason, this will lead to the edema and make the heart failure worse. So we don't recommend to use this one. Okay, bioglitazone, we don't recommend to use it. What about Glinides? Glinides belong to the sulfonylurea, and Glinides increase weight, and we don't need this one because the patient already obese. Okay, so we don't recommend to use it because the obesity and increasing weight. We're concerned about weight. Well, we try to select medication not cause weight gain, so that's not correct answer. Okay, what about linagliptin? Linagliptin decrease weight. That's great. Linagliptin decrease risk of heart disease or ASCVD. That's great. What else for linagliptin? I like this medication here, linagliptin. Okay, this medication decrease weight and obese, decrease risk of and control A1C, decrease A1C. So now we have the option for this linagliptin. So this is the correct answer here. I will clean this one. We don't need all this information here anymore because we have the correct answer now. So this is the correct answer. Okay. Next, which of the following diabetes medication most appropriate paired with the adverse effect associated with its use? Canagliflozin. Now we try to select the correct answer. Correct answer. Okay, we talk about side effect, adverse effect. Canagliflozin may cause urinary tract infection. I'm not going to answer the question now. Glinide, heart failure. Glipizide, weight loss. Liraglutide, lactic acidosis. Which one is correct, most appropriate? So we're looking for one correct answer only. Okay, I will start with the liraglutide and lactic acidosis. Yes or no? No. Okay, lactic acidosis. Which medication causes lactic acidosis? Metformin. Okay, metformin causes the lactic acidosis. Glipizide. Glipizide causes weight loss or weight gain? If you answer weight gain, this is correct, not weight loss. Okay, glipizide. Glinide, heart failure. No. The heart failure, which one? Bioglitazone. Okay.
Canagliflozin, urinary tract infections. Yes, all the SGLT2 increased risk of urinary tract infection. This is a correct answer. Okay. Okay, in this case, we conclude our lecture about diabetes mellitus, and let me go to the next slide. Okay, so in this case, we conclude our diabetes mellitus clinical pharmacology and drug therapy, and we cover all the medications, start from insulin to the Pramlintide to the GLP-1 such as semaglutide like liraglutide, Victoza, Ozempic. Then we move to the oral glycemic agent, start with the sulfonylureas, Metformin. Then we have acarbose, miglitol, DBB4 like linagliptin. Then we move to the SGLT2 such as empagliflozin and canagliflozin. We spoke about the effect of this medication on weight and the effect of this medication on protection from cardiovascular risk factors, prevent of cardiovascular death or prevent hospitalization due to the cardiovascular complications. So in this case, it's the best way to memorize this information here by creating a table about the group of medication, then the individual drug for each group, how this medication work and what is the clinical use for this medication. Then we move to the major adverse drug reactions, if you have any contraindications. And also we cover something about pregnancy. If we have pregnant women suffer from diabetes, gestational diabetes, for example, what is the drug of choice? So we have 3 medication on the list there. I hope this video may be good for everyone and provide beneficial information for your practice, for your study, and I wish you the best all and have a great day, everyone.